Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the channel. Today we will talk about diagnosis and treatment for cardiac achalasia. So this is part 2 as far as the topic is concerned. The link for part 1 is there in the description. Cardiac achalasia, as you now know, that it is due to the failure of lower esophageal sphincter relaxation and absent peristalsis in the lower part of the esophagus, leading to the dilatation of the esophagus. So symptoms of achalasia are insidious in onset and gradual in progression, and a delay in diagnosis is usually due to the misinterpretation of the typical findings by the physicians rather than atypical presentation of the disease. Many patients are treated for other disorders like gastroesophageal reflux disease before the diagnosis of achalasia is made. Patients who have a clinical history suggestive of achalasia, they require radiological assessment, manometric evaluation, and endoscopic evaluation to confirm the diagnosis. In radiological investigations, chest X-ray, it will show us a dilated esophagus with air fluid level, especially in distal part of the esophagus, and there will be absent gastric bubble. So as you can see in this picture, that this is the fluid and there is the air, so air fluid level is there. There is no air bubble in the stomach. Here you see widened mediastinum due to the dilated esophagus. Very clearly air is there and fluid, air fluid level more clearly visible in this lateral view, and there is absent air bubble in the stomach. Barium swallow. The characteristics features on barium swallow will be, of course, a dilated esophagus, incoordinated esophageal contractions, and there will be obstruction at the gastroesophageal junction, which will appear as a rat tail appearance, which is also called sometimes as bird's beak appearance. Here you can see that this is the barium which is being pent up in the distal part of the esophagus, and you can see very clearly the dilated esophagus, and this is the rat tail appearance at the lower end of the esophagus, which is also known as bird's beak appearance. In this picture you can see that barium swallow in a patient which we call as vigorous achalasia. There are multiple non-peristaltic muscular contractions in the dilated esophagus, and here you can see again a bird's beak appearance, because normally what happens that there is peristalsis, which is a wave of contractions and relaxation alternatively pushing the food bolus downwards, but here it is vigorous contractions which are not coordinated and not followed by relaxation. Endoscopy, it is a must. It will show us the narrowing or obstruction of the distal part of the esophagus, and it is essential to exclude the organic cause or mechanical cause of the obstruction. Endoscopic evaluation is generally recommended for most patients to exclude malignancies at the gastroesophageal junction, which may mimic primary achalasia clinically, radiologically, and manometrically, but actually it will be pseudo achalasia due to malignancy. So endoscopy is important, and this will show us a rosette appearance of lower esophageal sphincter on endoscopy. Manometry is the measurement of the pressure at the lower end of the esophagus, so that we can check out the motility and function of the esophagus. A tube is passed from the nose into the esophagus. The pressure of the sphincter and contraction waves are recorded. but this procedure has a risk of aspiration. So on manometry, there will be absent peristalsis. Then there will be incomplete lower esophageal sphincter relaxation after a swallow, and there will be increased lower esophageal sphincter pressure, which will be even more than 45 millimeter of mercury. Another manometric abnormality which is oftenly observed is in achalasia is that resting pressure in the body of the esophagus is slightly higher than that in the stomach. The simultaneous esophageal contractions, they will have an amplitude of more than 60 millimeter of mercury, a condition which is known as vigorous achalasia. In the management, we have got four options. One is pharmacological, the drugs can be used. The other one is pneumatic or forceful dilatation, or we can use botulinum toxin as an injection at the lower esophageal sphincter, or we can go surgically, what we call as esophageal myotomy. As far as pharmacological treatment is concerned, medical therapy, it can be used for the patients who are unwilling or unable to tolerate more invasive procedures for therapy. Of course, no treatment reliably will restore the functions in the body of the esophagus. Calcium channel blockers like nifedipine and isosorbide dinitrate can be used sublingually 10 to 30 minutes before meals, because we know that calcium ions, they are responsible for the activity of myofibrils and tension generation. So these blockers, they will act by decreasing the calcium entry and reducing the pressure in lower esophageal sphincter, so that allowing the food to pass onto the stomach, but their side effects like low blood pressure and headache should be considered. Botulinum toxin, it will prevent the release of acetylcholine, which causes the contraction of lower esophageal sphincter at the neuromuscular junction. Endoscopic injections into the lower esophageal sphincter, but it will need repetitive sessions. It is injected into the lower esophageal sphincter using the endoscope and causes local relaxation. It is effective in 90%, but if this effect wears off after several months, so 50% of the patients will require another treatment within an year. And side effect is chest pain soon after injection. Forceful dilatation, it is the treatment of choice. It is also called as pneumatic dilatation, in which a balloon catheter is placed in the esophagus and forcefully inflating the balloon within the lower esophageal sphincter. Tear is produced in lower esophageal sphincter by disruption of the circular muscles, which becomes relaxed and allow the food to pass into stomach. The balloon which is used in the United States, that is called Rigiflex balloon. Different sizes, 3, 3.5 and 4 centimeter. Smallest size balloon is used in first session, and if symptoms persist, gradually the increasing sized balloon are used, which is called as graded approach. Esophageal perforation may occur in 3 to 5% of the patients. It has a success rate of 60 to 90%. The advantage of dilatation is that it can be repeated if symptoms return. And this is how endoscopically the catheter is passed. The balloon is at the lower esophageal sphincter level, and then it is inflated so that it causes the relaxation of lower esophageal sphincter, and the food bolus will be passing into the stomach. This is the catheter with the balloon. Here the balloon is inflated. in situ. Endoscopically you can see. Now the different the techniques have been used for this. For example, the maximum diameter of the balloon is reported from 2.4 to 5 centimeter. The pressure to which the balloon is inflated, it ranges from 105 to more than 1000 millimeter of mercury. Then rate of balloon inflation, whether it should be rapid immediately or gradually we should be inflating the balloon. Then for how much time this inflated balloon should be there in situ. Different series they have used from several seconds to up to 5 minutes. Then the number of balloon inflations per dilating session, only once or even up to 5 times the inflation and deflation of the balloon can be done, but none of the variations in the technique have shown a significant change in the outcome. So it will depend upon personal experience. Then is the surgical treatment, which we call as myotomy. As the name indicates, it involves a controlled incision into the muscles of lower esophageal sphincter to cause it to relax. It has got a success rate of up to 90%. It was first performed by Mr. Ernest Haller in 1913. It can be performed either by an open procedure through the chest, which we will call as thoracotomy, or through the abdomen, that is laparotomy, or nowadays by laparoscopic techniques. So surgeon weakens the lower esophageal sphincter by cutting its muscle fibers, have been viewed as the primary alternative to pneumatic dilatation for achalasia. Modified Haller approach results in good to excellent relief of the symptoms in 70 to 90% of the patients. Reflux esophagitis, that may be complicated by esophageal ulceration, stricture, and Barrett's esophagus later on. It develops into 10 to 30% of the patients treated by surgical myotomy. As in the picture you can see, this is laparoscopically being done, and these are different ports which have been used through the abdominal holes, and then you do the myotomy of the muscles of the lower esophageal sphincter. These are the endoscopes, laparoscope trocar cannulas. So patient is placed in modified lithotomy procedure. Pneumoperitoneum is established and trocar is inserted. 4 working ports are then placed under direct visualization. So these are 4 ports, working ports. 1 port is for the camera. As you can see, these are the landmarks, and here in previous picture as I showed you, here these ports they are working through that. This is a laparoscopic myotomy being carried out. So these are the details of the procedure, operative details. You can check it out from operative surgery books. So entire myotomy spans approximately 9 to 11 centimeter, 3 centimeter below to 6 centimeter above the gastroesophageal junction. Mucosal perforations are repaired with fine absorbable suture. So Haller's myotomy is basically cutting muscle of lower esophagus and the cardia. Complication, as I just mentioned, is the gastroesophageal reflux disease. So Haller-Dawes operation is that just partial anterior fundoplication can be done. So complications of achalasia, of course dysphagia is there, so that may lead to malnutrition and weight loss. Then due to repeated infections or aspirations, there can be breathlessness and pneumonia, and carcinoma of the middle and lower esophagus due to chronic irritation by this food. So with that we come to end of this session. If you find it beneficial, please like and share it with your friends. Don't forget to subscribe the channel. Thanks for watching.